Okay, guys, the session is being recorded. You can hear me, right? Okay, awesome. So we're going to start by talking about the function of the integumentary system, aka our skin. So some functions include as a barrier. Okay, it's a physical protection. It's for sensory input. These are some of the main things that it does, okay? And it's there for support as well. Okay? So those are the functions of the integumentary system. So next is he's asking what are the main functions of each layer of the skin and how do they correspond to protect from bacteria. So in the epidermis, we have Langerhans cells. These serve as an immune function, okay? They're there for surveillance, basically. If something that's there that's not supposed to be there, these Langerhans cells, they recognize it and they instruct the body to go attack and get rid of the bacteria or the virus. Now for the dermis, which is the second layer, so this is the first layer, this is the second layer, there are these plexuses, okay, aka blood vessels, okay? So we know these blood vessels have blood in them. We know that blood have white blood cells, which are there to fight for infections. So this is how the dermis functions against bacteria, to protect it from bacteria, okay? There is blood supply in the dermis. In that blood, there are these white blood cells that provide protection. And then lastly, in the hypodermis, we have these same blood vessels that are there to attack any bacteria if there is bacteria. Okay, these are one of the functions of blood, is to protect from bacteria. Now, there are different layers. So there are 3 layers of the skin: epidermis, dermis, hypodermis. Now, when we're talking about specifically each one of them, they each have their own layers. The epidermis has 4 to 5 layers. The dermis has 2 layers. And the hypodermis is just 1 layer. So let's talk about the epidermis. The epidermis, okay, has 4 to 5 layers. 4 if we're talking about thin skin, 5 if we're talking about thick skin. So from the topmost layer, we have the stratum corneum. All skin types have this. Then below it, we have the stratum lucidum. Now there are 2 stars there because that is the difference between thin and thick skin. The stratum lucidum is present in thick skin. Okay, has the lucidum. The thin skin, no lucidum. Okay. Then below that, we have the stratum granulosum. Below that, the stratum spinosum, and below that, the stratum basale. Okay, the order is the same for both thin and thick skin, with the exception of the stratum lucidum. So thick skin is only found on our palms and soles of our feet. Thin skin is everywhere else. Okay? Now, in the epidermis, there are certain cells in there. We have keratinocytes, we have melanocytes, we have Langerhans cells, which we discussed briefly. We have Merkel cells and the basal cells. Keratinocytes, they produce keratin. Okay, that's where the keratin comes from on our skin. Melanocytes, they produce melanin. Langerhans cells is for immune function. Okay, if there's any invading bacteria, Langerhans cells recognize and attack. Merkel cells, getting a little messy. Merkel cells are for sensory, so light touch is associated with Merkel cells. And then we have basal cells, which is, think of basal cells as stem cells. Okay, so stem cells, what they do, they differentiate into whatever cell is around them. So if the body needs more keratinocytes or melanocytes, these basal cells become those cells. Okay? Now, there are three different types of glands on our body. We have merocrine, we have apocrine, and then we have holocrine. Okay, so for merocrine secretion, this type of secretion involves secretory vesicles. Okay, so this is basically exocytosis. So our sweat glands, for most of our sweat glands, are merocrine secretion. Water is just released through the secretory vesicles, they go through the duct, and they're released onto our skin. Now, the apocrine secretion is another type of gland, and this type does not use secretory vesicles. A part of the cell is pinched off. And that part is secreted. So these are sweat glands in our armpits, so our axillary region, and our pubic region as well. So this is why that area can get very stinky or smelly, because part of the cell is pinched off and is released, and the bacteria on our skin is able to feed off of these dead cell parts, right? And which produces the odor that we sometimes experience if we go a long time without bathing, or if we've had a long day. If it's just the merocrine, which is just secreting the water, bacteria can't really feed off of that. But for apocrine, parts of the cell is being pinched off and released. Bacteria is able to feed and produce this odor. So again, apocrine secretion are armpits and pubic area. And lastly, there is holocrine secretion. This one, the entire cell dies, and that is secreted. And is secreted. Okay, so this holocrine is for oil secretion. This is why oil on our face or on our hair, they have that consistency, because it's literally just cell guts, basically. Okay, the whole entire cell dies, and that whole thing is secreted, producing this oily substance. Any questions so far? Okay, so he asks here, where does nail production start? It starts at the nail matrix. Okay, the nail matrix is deep inside the nail root, and that is where the cells divide and they proliferate, and eventually our nail grows out. Okay, different areas of the nail. We have the nail root, which is on the inside. Then we have the cuticle, aka the eponychium. That is our cuticle. It is there to protect, make sure nothing goes inside of our skin. Then we have the hyponychium, which is the under part of the nail, of the free edge of the nail. Then we have the actual nail body. Below it is the nail bed. But this is why we have nails, is to protect us. That area is very, very sensitive, and that the nail is there for protection. Next, we're going to talk about the layers of the hair strand, okay, which is here at the bottom. We have the hair root, which is the bottom part, so the part that's inside of the skin, and then whatever is outside is known as the hair shaft. Okay, we're zooming in on this part right here. The hair papilla is the blood supply, and it's supplying the hair matrix, which is right here. Similar to the nail matrix, the hair matrix is where the hair actually grows and divides. We also have the medulla of the hair, which is the inside part of the hair, and then out close to the medulla we have the cortex. And then outside of the cortex we have the cuticle, which is this protective layer. The question asks, what is terminal hair? That is hair that has a set growth. Okay. Sorry, it has no growth. So ever wondered why our hairs, like the head on our hair, our beards, if you're a guy, they have no set growth. They grow forever. As long as you're healthy, taking care of yourself, your hair and beard, and also the pubic hair will grow forever and ever and ever. Now the hairs on our arms, on our legs, those do not grow forever. They have this pre-programmed hair length. Okay, once they reach that length, they stop growing. Thank goodness, otherwise we'd just be hairy mops. Okay, so the only hair that has no set growth is the terminal hair. Those can grow forever and ever. Now there are certain pigments in the epidermis. Consist of melanin, okay, keratin, which is a protein found in our skin, and also hemoglobin. So the amount of melanin we produce determines our skin color. A lot of melanin, darker skin color. Not enough melanin, a lighter skin color. Keratin is also found on our epidermis. This is also found in vegetables, orange vegetables. So carrots is the better example. You eat a lot of carrots, okay, you will become orange because of this keratin. You both have this, you're absorbing all this keratin, your body, your skin absorbs that protein, which gives you an orange color. Also hemoglobin, the protein in our blood. When it's bound to oxygen, it becomes red. When it's not bound to oxygen, it's bluish. Okay, so that determines our color as well. So if your body is healthy, the hemoglobin is binding onto the oxygen correctly, you're gonna have this reddish pinkish hue to your skin. If your body is not holding onto this oxygen properly, then your skin just becomes blue. It reflects the... Yes, Fanny. You can speak up. You don't have to raise your hand.
No, I'm good. Thank you.
Oh, okay. Okay. So the hemoglobin, depending on the oxygen content in our blood, that determines our skin color as well. Okay. So this question is redundant. What are the properties of melanin pigmentation? So the more melanin you have, the darker your skin color equals darker skin. Okay. Next question is what causes skin color to change? So any one of these primary pigments, okay, any one of these can cause your skin color to change. So if your body decides to start producing more melanin, you become darker. If melanin is not being produced, you'll become lighter. If you're eating a lot of carrots, okay, you're drinking a lot of carrot juice, you tend to become more orange because of the keratin. Okay. If, let's say, you're exercising, okay, you're losing a lot of oxygen, your skin becomes very reddish and pinkish. If your body is not using oxygen correctly, okay, your skin reflects that by showing itself as bluish color. Okay. So it's asking you to list the individual components of the integumentary system and explain their functions. So we talked about the skin itself, how it has the epidermis, the dermis, and again the hypodermis, which is the third layer. Okay, the skin has these appendages or these accessories, our hair, our nails, our sweat glands that we talked about, and sebaceous glands. And the function, so the function of hair is to protect against heat, protect against UV radiation, to cool us down depending on what area we're in. Our nails are there for protection, allows for gripping stuff. And our sweat and sebaceous glands, again, sebaceous glands are oil glands, which help to keep the body very moisturized. The sweat glands help to cool us down. If our body is overheating or exercising, then we sweat just to cool the body down and to maintain homeostasis. Now, burns. What are the degrees of burns? We have first degree, second degree, third degree, and we can even have fourth degree. First degree is just epidermis. Second degree is epi plus dermis. Okay. Third degree, that one goes all the way down to deeper tissue, so it's epi plus dermis plus hypodermis. And then lastly, fourth degree burn. This is very, very extreme. It'll go down to the bone. Okay. So there's a lot before you hit the bone. You have skin, you have connective tissue, you have muscle, you have fat. So for you to get all the way down to the bone, you're burning down a lot of structures, okay? So the method for treating a burn is known as alkaline formula. Okay? Just be familiar with it. You don't have to know it exactly. But part of it is they add fluids, IV fluids. They increase your caloric intake. They give you antibiotics to prevent infection. And they assist with tissue repair. So they might do skin grafts. So take skin from other parts of your body and put it on the burn just to help the skin regenerate faster. Okay. Now, an incision is a surgical cut. So a surgeon does this. An abrasion. An abrasion is just a scrape. Okay, you fall down your legs. That's an abrasion. A contusion is a bruise. A laceration is a deep cut. A puncture is done with a sharp or pointed object. Okay, so he does test about these. Just make sure you're familiar with them. I mean, this next question is what is the difference? Well, again, the definition of the differences. Okay, an incision is a surgical cut. An abrasion is a scrape. A contusion is a bruise. A laceration is a deep cut. A puncture is done by a sharp or pointed object. So there are stages of skin regeneration. You cut yourself, what happens next? Okay, there are 4 phases. First is the inflammatory phase. Immediately after the injury, your body releases these histamines that cause inflammation. Okay, the reason for this inflammation is that swollen tissue traps any bacteria or debris that might have gotten in and keeps it from spreading throughout the body. Okay. And next, after the inflammation phase, we have the migratory phase. The stratum basal cells. Remember, the stratum basal is the bottommost layer of epidermis. So these cells, they start migrating down, deep down towards the cut. Okay. So at first they were no longer there, right? Because they're up here. So in the second phase, they start migrating down. It starts the process of skin reformation. And once they migrate down, they connect with one another deep down there. Then we start the third phase, which is proliferation. These cells start reproducing more of themselves. So again, through mitosis, okay? They divide, they start producing more. It's filling up the space of the cut. okay, is now just being, instead of empty space, now it's being replaced by actual skin, okay? And during this proliferation phase, we have these fibroblasts, or fibroblasts make fibers, or collagen fibers, that start embedding themselves in the skin to give it its shape and its integrity. And next, lastly, is the scarring phase, okay? The cells of the stratum basal regenerate the epidermis completely. There is no longer the blood clot that has been dissolved. Okay, now what's remaining is just this scar tissue from this fibrin. Okay, the fibrin is the protein being released by these fibroblasts to help rebuild the skin. And that's it. What you're left with is just a scar after the injury. Now we're going to get into cancer, specifically cancer of the skin, okay? We have squamous cell carcinoma, basal cell carcinoma, and a more deadly type, melanoma, okay? Why is melanoma more deadly? Because it goes down all the way to your dermis, pretty deep down to the dermis, okay? So that can get very deadly. So the most common type of skin cancer is basal cell carcinoma, okay? So basal cell carcinoma is usually localized in the upper portion of your face. Squamous cell carcinoma is the lower portion of your face. And melanoma, they happen basically anywhere for the most part. Okay. For the sake of the exam, squamous cell carcinoma, lower portion of the face. Basal cell carcinoma, upper portion of the face. Now, since we're talking about, oh, sorry, I missed a question. So what is the most common type of skin cancer? Well, that's basal cell carcinoma, okay? So since we're talking about cancer, it's appropriate to discuss UV light, okay? UV light, or ultraviolet radiation, or ultraviolet light, comes from the sun, okay? Sun emits it. Now, there are two types of UV lights. There's UVA and there is UVB. UVA is the more powerful one, okay? It's able to penetrate down to the dermis. So this is what usually causes DNA damage, UVA. Okay? UVB is not as strong, so it only can reach the epidermis. Okay, that's as deep as it ever goes, is the epidermis. So this is what causes sunburn for the most part. And is responsible for vitamin D production. The next slide will get into why. Okay, so those are the effects of UVA and UVB. UVA is usually causes DNA damage just because it's so powerful. It can penetrate down to the second layer of the skin. UVB is less powerful, but it's enough to cause sunburn, and it's responsible for vitamin D production. Vitamin D. Okay. Now, dehydration, what are the causes of, actually before we move on, do you guys have any questions so far? Okay, awesome. So what are the causes of water loss? We have urination, defecation, bleeding, wound drainage, gastric drainage, and vomiting. All of these things can cause water loss in the human. All right. Now, there are two types of water loss. There's sensible, so what can be measured, And then there's insensible, cannot be measured. All right. So types of water loss that can be measured are urinating, defecating, so going to the bathroom, bleeding, wound and gastric drainage. These are usually done at a hospital and in containers that have volume measurements, and vomiting. Okay, all of these things can be measured quite easily. Now, what can't be measured quite easily is perspiring or sweating. Okay, because you can't really collect all the sweat that you have on your body, and if you did try to, a lot of it would evaporate before you can get into a container. Okay, and also breathing, respiring. Whenever we exhale, we release water vapor. Okay, we can't really measure the amount of water vapor we release. So changes in humidity levels and our breathing affects this insensible loss. Okay. So if we lose too much water, this leads to dehydration. Okay, some signs to look for, especially he's asking specifically on a patient's skin. What they test for is turgor. Okay, this is basically the elasticity of your skin. So if the doctor pinches your skin, okay, this is your skin being pinched, and it takes a long time for the skin to go back to normal, you're dehydrated. Okay, that's skin turgor, the ability for your skin to bounce back to its normal size and shape after you pinch it. Okay, so people, you guys can try it now. I'm sure you guys are extremely hydrated. Pinch your skin, you let go, it goes back to normal immediately. In a dehydrated patient, skin takes a lot longer to go back. Literally, you pull the skin, you let go, and it's as if somebody is still holding on to that piece of skin, and it takes a while for it to go back to normal, okay? Other signs to look for, you have dizziness, headache, you're tired, you feel thirsty, obviously, and you have muscle weakness, and your urine is very, very dark and yellow. Some signs to look in for kids, they're usually sleepy or drowsy, okay, more than usual. They're crying or they're not producing tears. So again, this is extreme form of dehydration. They have dry mouth, dry or sticky tongue, high fever, and for infants, their diaper is dry for more than 3 hours. Okay, a healthy child goes to the bathroom regularly. If they spend more than 3 hours, nothing comes out, no urine, no defecating. Usually, it's a sign that they're dehydrated. All right, now we're going to talk about vitamin D. So what is the role of vitamin D? Okay, the role of vitamin D, do you guys know?
Absorb and deposit calcium.
Exactly. It's specifically absorbing calcium. For depositing calcium, that's osteoblasts. But it absorbs calcium from our diet. Okay. Where is vitamin D3 produced? So this is what I was talking about on our skin. On our skin, on our epidermis, specifically, we have this protein called cholecalciferol, this molecule. Once this molecule is in contact with the UV radiation or UV light, okay, this starts a series of reactions that eventually produce equal vitamin D. Okay. So this cholecalciferol plus UV light creates vitamin D or calcitriol. Okay, calcitriol is the active form of this vitamin D. So next he's talking about rickets. So rickets, you guys know what rickets is? What hormone it's lacking? Rick, yeah, go for it.
The weakness of the bones?
What? Yeah, because of a lack of what hormone specifically? Or what vitamin?
Control?
Exactly, exactly. So people with rickets, they do not have sufficient levels of vitamin D. We said that vitamin D helps uptake calcium from our diet, okay? So if there is no vitamin D, then we are not absorbing calcium, and that calcium is not being deposited into our bones, okay? Our bones become weak and brittle. So this leaves with very weak bones, okay? This is specifically in kids. This happens in kids. So what causes it? So what is rickets? Weak bones due to lack of vitamin D, which kind of answers the next question. What causes rickets? Lack of vitamin D. Okay. Now the physical traits of this condition, the most common one are bow legs. Okay, bear with me here. These are normal human legs. They're straight, they're strong. When you have rickets, okay, calcium is not being deposited into your bones, so they're very weak, they're brittle, they can't support your growing body. So what eventually happens is your legs become curved or they become like bows. Okay, there's literally this curvature in your leg because you did not have enough calcium growing up to make your bones strong. Any questions? Okay. Next, we're going to take a look into some skin pathologies or skin diseases. So jaundice. Can you guys tell me what that is? So that's usually an issue with the liver, okay? And your skin is yellow. Why? Because there is bile in your blood. So bile is not supposed to be in your blood. How does it get there? Well, the bile ducts or the bile channels are somehow blocked. This bile starts to build up. Eventually, the liver can't hold all of this, so it starts seeping into your bloodstream. Once that's circulating in your bloodstream, it turns you yellow. Okay. Vitiligo is an issue with melanocytes. So these cells that produce melanin, they start dying off, making your skin color lighter than the rest of your body. Albinism. Okay, so with vitiligo, you do have melanocytes, but something later in life triggers this, and they start to die off, and melanin is not produced. With albinism, you never had them to begin with. No melanocytes making melanin. Okay, so you're very, very pale. The opposite of albinism is melanism. Okay, that's when the body is producing too much melanin and you're a very dark color. Now, what causes stretch marks? So stretch marks arise from the collagen and elastic fibers losing their strength and integrity. Just like a rubber band, okay, if you stretch it too much or past its limit a couple times, eventually it loses its elasticity. It's not as strong as it once was. Okay, same thing happens with skin, with pregnancy or with weight gain or weight loss. Okay, the intensity of this stretch is too much. It's too much for the skin to handle, basically. So these collagen and elastic fibers, they start to break down, and they're not able to be, they're not as strong as they once were, which causes stretch marks. Okay. Next question is, what is dermatitis? Whenever you see itis, that usually means inflammation. Inflammation due to what? Due to infection. So dermatitis is inflammation of the skin or the dermis. Okay. So different causes of dermatitis. We have jaundice that we already talked about. It's yellow color based because of this buildup of bile. What we did not talk about was the pituitary tumor. The pituitary gland makes MSH. MSH stands for melanocyte stimulating hormone. Guess what it stimulates? It stimulates the melanocyte cells. Once the melanocyte cells are stimulated, we produce melanin. But here, because of a tumor, is being released in excess. So our body is producing melanin in excess. So this can cause the skin to darken drastically, which is similar to Addison's disease. Okay, it's a disease of the pituitary gland. It's not necessarily a tumor, but excess MSH is being released, causing the skin to become darker. Okay, and then again, vitiligo, we lose melanocytes. We lose the melanocytes, we lose our color, right? Because the melanocytes, they produce melanin. Sorry. All right, we're going to talk about tissues. I believe you guys went through this for exam 2, so this is not going to be as detailed, but just in case he asks. So 4 tissue categories, we have epithelial tissue, connective tissue, muscle, and nervous. Epithelial has squamous, cuboidal, and columnar. Muscle tissue, well, before I move on to from epithelial, these are the cell types. So their shape. And there's also the way they're layered. Okay, so they're either simple or they're stratified. So what does that mean? Well, you can be simple squamous, simple cuboidal, or simple columnar. Or you could be stratified squamous, stratified cuboidal, or stratified columnar. All that means is that it tells you about the layer and the cell type. Okay, so this is layers right here. So if you're simple squamous, that means you're just one layer of squamous shaped cells. If you're stratified cuboidal, that means you're many layers of cuboidal shaped cells. Cuboid shaped cells. Pretty straightforward. Now for connective tissue, this is where it gets a little tricky. Well, it's not tricky, it's just a lot of information. Let me delete this. For connective tissue, we have connective tissue proper, connective proper. We have cartilage as a category. We have bone, and then we have blood. Okay, connective proper. Now, connective tissue proper is further divided into loose connective tissue and dense connective. Loose connective tissue is further subdivided into three categories. We have areolar, we have adipose, and then we have reticular. Dense connective tissue, also subdivided into three categories. We have regular, dense connective, we have irregular, and then we have elastic. Then regular is divided into tendon and ligaments. Okay, tendons is muscle to bone, ligaments are bone to bone. These are the classifications of connective tissue. I believe he did test you guys on this, but just in case. Next, we're moving on to the muscle tissue. It has skeletal, smooth, and cardiac. Okay. And the nervous is just one tissue type. It has cells known as neurons, and they're just there for communication. Okay, communication with the body and the outside world. Next question is, what is transitional epithelium? This is an epithelium located in the bladder. When the bladder is empty, these cells open up like circular. When the bladder is full, these cells become flattened. The reason for this is so that the bladder can maintain its integrity. Okay, it's constantly being filled up and emptied. That way, the bladder is protected. Okay. He specifically asked for a simple cuboidal epithelium. These are located in the glands, so sweat glands, oil glands, ducts, so sweat ducts, oil ducts, and parts of the kidney tubules. Okay. Now, we're going to talk about the hormones that regulate blood calcium levels. We have PTH, calcitriol, and calcitonin. PTH and calcitonin are similar. Can you guys tell me how? What do they do to blood calcium levels? Do they bring it up or do they bring it down? They increase blood calcium levels. Okay, so if blood calcium is low, PTH and calcitriol bring it up. Now, calcitonin does the opposite effect. Okay, it lowers blood calcium levels. So if calcium is high, calcitonin brings it down. Okay, now these three hormones act on three organs: our bones, our intestine, and then our kidneys. We'll discuss that in the next slide. So calcitriol and parathyroid hormone do the same exact thing for the most part, okay? So with the intestines, we increase absorption. Why? Because blood calcium is low. We do not want blood calcium to be low. So when it's low, calcitriol and PTH work to raise it. So how does it raise it? Well, it acts on the intestines to increase absorption. So you're eating calcium, your body absorbs that calcium and puts it back into the blood so it can raise the levels. Okay? Now that's just the intestines. Now for the kidney, okay, we want to raise blood calcium levels. So do we want to pee the calcium out? No. So the kidneys retain calcium. It holds on to the calcium. It does not want to let go of it. And then our bones. Lastly, our bones. So our blood calcium levels are low. We want to increase blood calcium levels. So what happens? We break the bone down. So osteoclasts activated to break the bone to release calcium from the bone and put it back into the blood. Now that is for PTH calcitriol. Calcitonin does the opposite effect, okay? But it still acts on these same three organs. So calcium levels, so blood calcium is high. Calcitonin works to bring it down. So how does it do that? Again, those same three organs, our intestines, our kidneys, and then our bones. So we want to work to bring down blood calcium levels. So on the level of the intestine, do we want to absorb calcium levels or do we just want to take it out of the body? Again, blood calcium levels are high. We want to lower it down. Is absorbing calcium a good idea?
No.
Exactly. So there is no absorption. It blocks absorption because we don't want to absorb more calcium. We're trying to get rid of it. Same for the kidneys. We're trying to get rid of calcium. Do we want the kidneys to hold on to the calcium or do we need to pee it out?
Pee it up.
Yep. So no retention. So we lose the calcium from the kidneys. And then our bones, blood calcium is high. Do we want to remove blood from the calcium from the blood or do we want to put calcium back into the blood?
Remove it?
Remove it from the blood, exactly. So what removes calcium from the blood and puts it into the bone? Osteo what? Osteoblasts. Okay, they build up the bone. Build up bone. How does it do that? Well, it takes the calcium in the blood and deposits it into the bone matrix. You guys understand how this works? Because he loves to ask about this. Okay. Next, we're going to talk about bone cells. There are 4 types. Okay. You guys should be familiar with these. Osteoprogenitor cell. What is that? What's the function of it? It's like a stem cell. Okay. So it can either become the osteoblast, it can become the osteocyte, or become the osteoclast, depending on what the bone needs at the time. Next, we have our osteoblasts. Does that build up the bone or break down the bone?
Forms the bone.
Yes, so it forms it. Osteoclast, does it build it up or break it down?
The bone.
Yes, perfect. It breaks it. And then lastly, we have the osteocyte, which is the actual bone cell. Okay. All of these other cells They are still bone cells, but they're accessories. They help the osteocytes, okay? The osteocyte has the information, it has the DNA inside of them. These osteoblasts and clasts, they just work to help build bone matrix. It's not the actual bone cell itself. Now, the importance of the lacuna. The lacuna are these small little spaces, these hollow spaces found in the bone, okay? And they house the osteocytes. Okay, so inside of those little holes, we have the actual bone cells living inside of them. This question, what is the function of each bone cell? We just talked about it. Osteoprogenitor is a stem cell. It becomes one of these other cells if needed. Osteoblasts, they form the bone matrix or they build it up. Osteoclasts, they break down the bone matrix. And then osteocytes is the actual cell. Now, what is the function of the skeletal system? The main function is for movement, okay? It allows us to move. It also helps to produce heat to keep our body warm, and it provides protection for our organs. Another function that people don't know about is blood flow, okay? Our veins are able to pump blood because of the skeletal system moving, okay? That squeezing mechanism is due to the skeletal system, okay? So if we're sitting all day, blood flow is not flowing as efficiently as it should be, because blood flow is a requirement of skeletal movement. Okay, so there's the different anatomical areas. Oh, let's not worry about that. That question is not on there. Jesus. Alright, now list one example of bone classifications. So we have flat bones, we have sutural bones, we have irregular bones, we have sesamoid, long bone, and short bone. So an example of a flat bone is the sternum. Example of a sutural bone is our cranial bones. Okay, they're joined together by sutures. Irregular bones are the vertebrae. Sesamoid bones is the patella or our knee joint, or kneecap, sorry. Long bone is the humerus, which is our arm, or femur, which is our leg. And then the short bones are carpals and tarsals. Carpals is the wrist bones. Tarsals are the ankle bones.
Oxygen, you should get -2, right? So if you have -4 oxygen, you get +5.
So next is the bone growth. Sorry, that's really loud, right, guys? Alright, anyways, bone growth. What are the effects of exercise and bone growth, maintenance, and remodeling? So bone growth is, sorry, so the effects of exercise with bone growth and maintenance is there's this dance going on between osteoclasts and blasts.
Let me do this one another way. So let's say you have people 4, right?
Okay, so as we're working out, our bodies are building and breaking down the bone to meet the calcium requirements that the body now needs. Okay, so what is the epiphyseal plate? The epiphyseal plate is where bone growth occurs. This is in children. Okay, children.
And so forth.
So this is the bone. I'll try to draw a bone. Okay, the middle part is the diaphysis. And we have the two ends known as the epiphyses. In the middle part right here, that is cartilage when you're growing. That is known as the epiphyseal plate. Eventually, as you're getting older, it becomes the epiphyseal line, which is bone, which is just the suture line right here where the plate used to be. So that's the difference between the epiphyseal plate and the epiphyseal line. So the plate is for children, it's cartilage. The line is now, it is no longer cartilage, it has become bone. It is a suture line for the most part. Okay. So what causes the epiphyseal plate to close? Well, as you're growing up, your body goes through puberty, it releases hormones, specifically growth hormone, which activates this bone growth. Okay. Next, we're going to talk about the primary ossification and secondary ossification centers.
Okay, this one is something. This one is something else.
So the primary ossification.
This one and then to get to the one.
That's a lot of fun. So the primary ossification center has to do with endochondral ossification. This is one type of bone formation. The second type is known as intramembranous. So whenever you hear primary ossification and secondary ossification, know that they're talking about this endochondral ossification. These are the steps. You have this hyaline cartilage template with the primary ossification center. So the primary ossification is the first site of bone growth. Okay. So the second step that happens is that this cartilage slowly becomes bone. Okay. And right here we're on the third picture. And then eventually blood vessels start coming in where the bone is. Okay. Then the fourth step is the bone is completely formed. It is no longer cartilage. Okay. So now we have these secondary ossification centers that start showing up on the end. Okay. So it's similar to the primary ossification center, except it's the second part where bone growth happens. The hyaline cartilage deteriorates, bone starts filling in that space, and eventually blood vessels come in through, and they start forming themselves.
You don't have to just tell me the problem.
Okay. So endochondral ossification is for the bone formation of most bones. Most of the bones in our body go through this process. Now the second type of bone formation is intramembranous. The bones of the skulls, the mandible or the jaw, and the clavicles form through this ossification type. Okay, it's called intramembranous because inside of the membrane there is no cartilage. It's just bones. The osteoblasts just start depositing these bone materials randomly. Okay, and then eventually they connect, and it just becomes one big bone. So this is the clavicle, for example.
So the first thing we're gonna do.
So endochondral ossification uses cartilage, and it has the primary and secondary ossification centers. Intramembranous does not use cartilage.
Yeah, so addition.
Okay, and there are no primary and secondary ossification centers.
Yeah.
Bone is just deposited randomly until it fills up the space.
Like OIL, addition is using, and the weight is.
So some of the fractures to look at, there are two classifications. We have displaced versus non-displaced. Displaced means the bone has moved.
The first thing we're gonna do.
Non-displaced, the bone has not moved. No movement.
Oxidation state of each of these, right? So we mostly have the oxidation state of F equals.
So the type of bone fractures we have open, where it breaks through the skin. We have transverse, where it literally just cuts across horizontally, fully. Okay. We have green stick, where the green stick is horizontal, but it doesn't take the whole length of the bone. It's just part of it. Okay. Then we have a comminuted, which is basically the bone is shattered. Okay, there are a bunch of bone fragments.
Okay, let's try to assign the state of.
And then we have segmental, which is two parts of the bone has fractures. Okay, we have a closed fracture, which is similar to the open. where the bone breaks completely through, but it remains in place. It doesn't tear through tissue, it doesn't tear through skin. Then we have spiral. Spiral is just what the name indicates. Okay, any twisting motion, there is a clear twisting cut of the bone due to this twisting motion. Okay, and there's linear, which is just a straight line, which is usually vertical. And then there's impacted, which happens with the vertebrae, for example, where these bones are smushed on top of one another, which causes sort of causes it to shatter almost. Okay, now fractures and how they form. The first step of a fracture is extensive bleeding. Okay, there is a big blood clot that happens.
We don't know what chromium is. The chromium is exposed. So
okay. Second step, we have an internal callus that forms, which is cartilage. Okay. The third step, that cartilage or this internal callus becomes bone. Cartilage becomes bone, and the blood vessels start going back to where they were. Okay? And then lastly, the fourth step is the external callus. Alright? There's a swelling that occurs, and then there's this external callus that happens, which is evidence that the bone has been broken or fractured. Okay, this will remain. This does not heal completely. Alright, almost done. Lastly, we're going to talk about some bone pathologies. Osteoporosis is the bone is breaking down faster than it can rebuild. So, more osteoclasts,
more negative
and less osteoblasts. So this causes small pores in the bone. Okay, hence the name osteoporosis. It has little pores, little tiny holes in the bones where it's being broken down. Then we have osteomalacia, which is a softening of the bone due to vitamin D deficiency, right? Because we're not absorbing calcium and they're not being able to be deposited into the bone, so the bones are soft. We have osteomyelitis, indicating inflammation or infection. So this is infection of the bone, okay? This is an infection. And we have osteopenia. Osteopenia is similar to osteoporosis, where bone is being broken down. So osteoclast production is much more than osteoblast production. Okay?
It becomes more positive or more negative.
Now, osteopenia is the first level. Okay, if that is left untreated, then we now have the second level, which equals osteoporosis. Okay. So osteopenia is the first level of bone being broken down faster than it can rebuild. If that is left untreated, then osteoporosis comes into play, and that is very painful. Next, we have osteopetrosis, which is bone hardening, and then osteosarcoma, which is cancer of the bone. And then lastly, we have Paget's disease, which is excessive bone breakdown, except that the bone is being reformed, but is being reformed abnormally. So people are left with big chins, big foreheads, because of this abnormal rebuild or this abnormal reformation. And then lastly, what is the palliative treatment for osteoporosis? That is just medicine. Okay, painkillers for the most part to help deal with the pain.
Oil is also
All right, that's it. Any questions, my Dennis? I'm sorry, I got a little loud at the end. There's another tutor working here.
No, it's okay. Thank you.
Yeah. Can I have your ID, please? Your
Yes.
student number?
Yeah.
You can just text it to me on the chat.
60 plus 3. So you see, negative or you decrease in